Welcome to today's Neuropathy Association webinar, Dealing with Diabetic Neuropathy on a Day-to-Day Basis, presented by Debbie Hinnon and Dr. Stephen Maynard. In a moment or two, we will turn our program over to our first speaker today, who will be Dr. Maynard, who will actually begin today's presentation.
This is Dr. Stephen Maynard. I'm a neurologist in Detroit, Indiana, and I'm glad to have everyone here on the webinar on diabetic peripheral neuropathy. What I'm going to start off with is go through some anatomy and physiology of diabetic neuropathy so you can have a better understanding of the treatments that we have available and how they work. So we'll start out with a plain old-fashioned nerve cell that we have here. Nerve cells have little fuzzy fibers at one end called dendrites. They often pick up material, the main cell body, and then a long fiber called an axon that goes down to the nerve endings. If this was a motor neuron, you'd have the dendrites picking up information from the spinal cord of the brain, go to the cell body, and then go down the axon to a motor fiber to contract a muscle. If this was a sensory fiber, say for pain, temperature, position, the nerve ending would pick up the signal here, transfer it to the axon, and then up into the spinal cord. And the peripheral nervous system is what we're talking about today, and that is anything that is not the central nervous system. Central nervous system is the brain and the spinal cord. Anything else is the peripheral nervous system. And we have the motor roots coming out of the spinal cord and the sensory roots going into the spinal cord. And when these are involved in the diabetic neuropathy, you can see if the sensory root is involved, you're going to be having problems with numbness and tingling and pain and loss of sensation. If the motor root is involved, and both can be involved, this will cause problems with weakness. Also very important in the diabetic neuropathy is we call the autonomic nervous system. These are the nerves that control the central internal functions of the body, such as blood pressure, heart rate, and the gut. What you see here is part of the system is controlling the blood vessels, the size of them. This is how your body maintains blood pressure. In a diabetic, you can lose this signal going to the blood vessels, and this can cause a drop in blood pressure. These nerves also regulate the gut. This is why people with diabetes have trouble with food moving through the gut the way that it should. And the nerves also control bladder function, they control sex function, and so all of these can be involved in the diabetic neuropathy. The symptoms in diabetic neuropathy, if the sensory fibers are involved, there'll be numbness, where you can't feel something. This usually begins, we call distal more than proximal. What that means is the longest axons are affected first. So usually the numbness and tingling will begin in the toes and work its way up the legs. Usually by the time the numbness makes its way to the knees, then the fingertips begin involved as well, and it keeps moving towards the central part of the body. So there can be sensory loss in the diabetic neuropathy. If the motor nerves are involved, which they often are, you can have weakness, and this usually, again, involves more the distal parts of the body. So the weakness will begin in the feet first, move up to the legs, then eventually will involve the hands. The muscles in the distal part of the body, such as the feet and hands, will begin shrinking up. That's what we call atrophy. And in addition to sensory loss, you have what's called paresthesias, which are very, very unpleasant, tingling, burning sensations. They can be described as a sharp shooting sensation, can be quite unpleasant for the patient, and sometimes are actually the most unpleasant symptoms, way above the sensory loss and the weakness that you can get in the diabetic neuropathy. Because of the loss of sensation from the feet, the diabetics often have difficulty walking. We call this a sensory ataxia. In simple terms, basically, the brain does not know where the feet are, and you end up walking like you're drunk because your legs are on autopilot, and you can be very unsteady. The term in neurology, we call it a positive Romberg. Have the patient stand up, close their eyes, and they fall over. That's a test we do in the office. What the patients will experience on their own is very, very commonly they'll be in the shower, close their eyes, shampoo their hair, and they end up hitting the side of the shower stall because their brain, again, doesn't know where the feet are, and they're very unsteady without some visual clues to keep themselves balanced. The autonomic symptoms that I mentioned a little bit 2 slides ago is a sudden drop in blood pressure. When you stand up, the blood pressure drops very suddenly. You can actually pass out and become injured from this. The autonomic nervous system controls the heart rate and how fast and how slow the heart goes. And if there's damage to these fibers, they can have rapid heartbeat, slow heartbeat, and that can cause a problem. In the males, you can have problems with erectile dysfunction, and in both males and females, you can have problems with bladder control, again, because of the autonomic damage from the diabetes. And the reflexes that we have when we check the patient are usually decreased Usually the ones in the feet are lost first, then the knees, then the wrists, and then up by the elbow. And we'll see changes in the skin where the skin is not receiving the nerve signal the way that it should, so the hair often falls off, especially in the males, and we see all kinds of changes in the skin. You can see the coloration here, which is quite typical for a diabetic, and same thing here with the toes. This is a combination of the damage to the nerves and a combination of damage from the lack of blood supply, and both are going on at the exact same time in the diabetic here. Tests that we can do to determine a neuropathy is a test called an EMG, where electrodes are placed down the skin. We measure how fast the current can be transferred through a nerve, and we can also put little tiny needles into a muscle and see are they receiving the nerve signal the way they should. There are many, many causes of chronic nerve damage. Diabetes, hands down the most common one. Lack of nutrition, say from alcohol, is probably number 2. Thyroid conditions can cause it, hereditary things can cause it, but the symptoms are all the same whether it's diabetic or not. Of course, the focus today will be the diabetic neuropathy. Again, this is the most common neuropathy that exists on the planet. A major chunk of the population here is suffering from diabetic neuropathy. And some data we have is that over a third of patients who have diabetes for 10 years have got the diabetic nerve damage, and at least half of them who have diabetes over 25 years suffer from the nerve damage. A big chunk of patients with diabetics have got foot ulcers. This is a major and complication of the diabetic, both neuropathy and lack of blood supply, and is a major cause of a disability in this disease and a major cause of expense. Physiology here is this. It's very simple. All complications of diabetes, no exception, are due to damage of blood vessels. The high blood sugar causes a lot of byproducts to be made. All of them are damaging to the interior wall of blood vessels, and so they get damaged, and then the blood cannot flow through them. This is why patients with diabetes will have strokes, the heart attacks, the lack of vision, and the kidney problems, and in our case here, lack of blood supply going to the nerves. And so when you have a nice healthy nerve, healthy blood vessel rather, having a nice healthy nerve, as the blood vessel begins to get blocked from damage from the high blood sugars, the nerve begins to dwindle off, and then as it goes further, we have a lack of blood supply, a lack of nerve cells, and they simply die off. And this is the underlying cause of the diabetic neuropathy. You have sensation in your feet for a very good reason. This is to protect you. And if you get say a stone on your foot or a cut or a burn or whatever, you pull away to protect the body. We've all heard recently the news story about a famous TV personality who was sued because he recommended hot packs to the feet, and a patient with diabetic neuropathy did not feel the temperature is too high and ended up burning the feet. So the loss of sensation of the feet is a major cause of the damage to the foot. It also is caused by a lack of blood supply because they're not getting good circulation down to the feet. Traditional treatment for the the burning and sharp pains that we have in diabetes are medications like amitriptyline and imipramine. These are medications that they were invented for depression, and these stabilize nerve membranes and help the pain. They're both good. Gabapentin and pregabalin are your Neurontin and Lyric. These were invented for epilepsy, and they also help the pain in the feet. Then you have your duloxetine, which is Cymbalta, and you have your NSAIDs, which are all very beneficial for the treatment here. We have other treatments. We have exercise, which is very good. I simply cannot recommend exercise enough for a diabetic. It helps with circulation. It helps with getting the sugars under control. It helps Parkinson's disease. It helps strokes. Add on. I was lots of rehab for this. Now, what I've been talking about all along are we call the positive symptoms, the antidepressants, the seizure medicines. These medicines help the stinging, the burning, the sharp shooting pains. That is good. I'm not putting that down. But they do nothing for what we call the negative symptoms. Remember, we have a loss of sensation. We have the sensory ataxia, balances down because the brain doesn't know where the feet are. We're having loss of bladder function, loss of sexual function in the males, and again, that problem with the drop in blood pressure. So as good as those medicines are that we have, we need something more, and of course, we have that. I mentioned you earlier how many patients have the diabetic neuropathy. look at the pain. This is the smallest chunk of patients with neuropathy have the actual burning, sharp shootings pain. The middle chunk has a sensory loss. The feet are numb. They can't feel them. Look at the biggest group here, asymptomatic. What do we mean here? I'm called to see a patient because that patient has just had a stroke for diabetes. We do a top-to-bottom neuro exam, and they deny any pain. They deny any numbness in the feet. Their reflexes are gone on examination. I will check them for, say, pinprick sensation, vibratory sensation. Do you feel a tuning fork? No. Well, the feet are numb. They actually have the diabetic neuropathy, and it's asymptomatic. This is when I like to get patients. If I can get them in the asymptomatic stage, I can treat it and often prevent it going to the sensory loss and then to the pain. I can treat patients no matter what stage they're in with the neuropathy. If I catch them early enough, it's much easier. Earlier is always better with anything, as you can imagine. Now, the treatment we're doing is called L-methylfolate. I'm going to explain some physiology to you. Folic acid is what you obtain in your diet. Folic acid does absolutely nothing whatsoever for nerve cells. Nerve cells must have L-methylfolate to stay alive and to metabolize. What happens in the diabetic is that, as I said earlier, we have a lack of blood supply going to the nerve cells, so the nerve cells simply cannot make these 1, 2, 3, 4 steps to get to L-methylfolate, and so they end up dying off as a result. So the idea came, why don't we give the patient L-methylfolate directly, no metabolism required, and the nerve cells can now stay alive and actually repair themselves. So this is the L-methylfolate, which is in the product we'll talk about later, called Medinex. Not to get too much into biochemistry here, but this is just being a little bit, say, facetious to the insurance companies. They'll say, well, gee, you don't need to take L-methylfolate, which is Medinex. Why don't you just take folic acid, and it's the same doggone thing? No, it's not. Look at the rings right here. These rings right here do not match these rings right here. So the folic acid, which is over the counter, is nowhere the same as the L-methylfolate, which is a prescription for the diabetic neuropathy. They are completely different. Just need the insurance companies to kind of figure that one out here. What we're having with the Medinex, which is the L-methylfolate, is actual regeneration, regrowth of the nerve fibers. If you look at a normal biopsy right here, these little tiny black lines up and down are the little tiny sensory fibers. In diabetes, they're lost, almost none left whatsoever. After 6 months of L-methylfolate, we're getting the little lines back. So we're actually getting biopsy-proven regeneration of the axons. This is just one patient, and this has been verified in multiple patients. This is a major, major breakthrough in diabetic neuropathy. For years, we were just treating the pain, the burning, the tingling, and that's good, that's okay, but we weren't getting the nerves to regenerate. What we're doing here with L-methylfolate in the Medinex, we are actually treating the cause of the pain and the cause of the neuropathy, and it gets better. So that is a very, very good situation here. Now, diabetic treatment, nothing substitutes good control of diabetes, and your diabetes, we're talking diet, exercise. Even though I'm not the diabetologist, I'm just the neurologist, when I see the patients, I emphasize these two quite significantly, because patients think, well, I'll take my metformin and that's it. My sugar's under control. No, you have to diet, exercise. These are tied for first place. I have my own teaching of patients. I will tell them your medications, even if it's insulin, is secondary. You've got to, watch your diet carefully, exercise regularly. One or the other is not enough. You need to do both. That's how you treat the neuropathy. And what we're doing here with the nutritional management is the Medinex. The Medinex, again, is L-methylfolate. Now, this is a medical food. What that means is that this has something that the FDA calls GRAS, G-R-A-S. What that stands for is generally regarded as safe. What we're meaning is that the Medinex is very, very safe. It does not have any concerns regarding bone marrow, liver, kidneys. It can have no organ damage being caused by this product. It cannot have any major drug interactions, so it doesn't matter what medication the patient is on. In summary, I'd like to reinforce the fact that it's very important to try to diagnose diabetic neuropathy as early as possible to prevent the complications, and it is always paramount to remember that good control of diabetes is the most important feature of treating diabetic neuropathy, and the good control of diabetes consists of proper diet and proper exercise. We also have nutritional options to treat diabetic neuropathy. And I thank you for your attention. I'd like to now turn the table over to Deborah Hinman, who can talk about the management of diabetic neuropathy on a day-to-day basis.
Thank you, Dr. Maynard. This is Debbie Hinnon. I'm an advanced practice nurse and certified diabetes educator in Wichita, Kansas. I wanted to spend some time with you talking about educational considerations. Our patients with diabetic neuropathy struggle on a day-to-day basis to deal with all of the issues around diabetic neuropathy. I want to share with you a lot of the concerns that our patients have. This study has shown concerns that are of importance to the patients regarding them being very worried or extremely worried. And as you look at this, going blind, as I think we've known, is the number one worry that our patients have. But right under that is the worry about amputation, losing a limb. And as you begin to glance down through this entire list, many of the worries that our patients have are related to the neuropathies that we are talking about today. Foot problems, numbness in the hands, in the feet, nerve injury or neuropathy, tingling, a lot of these, sores that won't heal. These are worries that, as you see in descending order, are big concerns for our patients. So we know it as a worry as health professionals, and our patients have many worries that are similar to this. The impact of peripheral neuropathy is I think, very striking. Our patients are so concerned and worried about the painful neuropathy. We as providers and clinicians and educators are worried about sensory neuropathy. But as this progresses or deteriorates, probably is a better word, the impairment increases and the painful neuropathy begins to have an effect on our patients' quality of life. The serious problems, though, when we talk about long-term complications, happen when the patient actually loses sensation. At that point on the right-hand part of this screen, we know that there's a risk for foot ulcers, infections, osteo, Charcot, and, of course, potentially surgery that would include amputations. So the patient is relieved sometimes because it doesn't hurt anymore. We, as educators and clinicians, are very worried because now truly serious problems are more likely to occur. Increased mortality and increased cost. The next slide then gives us a bit of a beginning thought about what we need to do. And as Dr. Maynard shared with you, the options are related to controlling the diabetes, some medications, and things that we need to do. I wanted to expand our thoughts just a little bit. We must have good control of the diabetes. That is absolutely job number one. So everything we can do to help our patients eat carefully, exercise as they can, and of course, if someone has neuropathy, that needs to be a very serious consideration for helping that person do something safe. For instance, putting their feet in the exercise bicycle so they know where they are, as opposed to walking on rough ground where they may not be able to know where their feet are and have problems. Diabetes meds are much different than they used to be. There's lots more options. But pertinent to our topic today, foot screening and assessment. That needs to be integrated into everything we do. And as we've had very good luck with Metanax, that prescription for L-methylfolate with the other B6 and B12 derivatives has been something we've had very good luck with when we combine that with good diabetes control. And of course, meds for the neuropathic pain may be necessary as well. I tell my patients it's really important that you can cope with this, but it's critically important that we do what we can to help that nerve heal. And so good blood sugars and Metanax seem to be a great combination to help with that. So let's roll up our sleeves just a bit and talk about that neuropathy. There are signs and symptoms that we know our patients have, and it's, I think, important that patients understand that they may unfold in a sequence. Very often the symptoms that are small fiber are the ones that patients begin to notice early on, prickling or tingling. Last week I had a patient say, "Debbie, it feels like my socks are bunched up under my toes." This may deteriorate to aching pain or burning pain or lancinating pain. People may lose sensation related to heat or cold, decreased sweating. They may then end up with total numbness. Now, the signs on the right-hand side of this talk about vibratory perception, and patients really can't tell whether they've lost vibratory perception. We have to do that test to help them know that. There may be changes in the reflexes and, of course, sensation, and can a patient even feel where their feet are, where their toes are, and then, of course, those pains, deep pains. So as you look at the caricature of this person, very often we see with peripheral neuropathy, that means farthest away, that the problems begin in the big toe, and it's bilateral, and it works its way up. It may also, of course, happen in the hands, and that may be soon to follow after problems with the feet. So we sometimes will call it glove and stocking neuropathy, but it indeed may progress up the legs and or up the hands. Now, from a clinical perspective, once the person is diagnosed, the red arrow in the lower right-hand area shows us that there may indeed be some subclinical issues happening, and nerve conduction abnormalities may be occurring before there's any symptoms that let us know that there are changes. Vibratory sensation is typically lost before the sensation with the monofilament, and then reflexes may be the last that are changed. So those changes that occur may then be tied with symptoms anywhere along that path. So the symptoms may occur even before the person is actually diagnosed with diabetes. My nephew was diagnosed with diabetes because he went to the doctor and said, I can't stand on my feet all day to work. And the doctor said, it sounds like diabetic neuropathy. And Jeff said, I don't have diabetes. Well, of course, the doctor did testing and did blood sugars and A1C, and indeed he did have diabetes. So some of those symptoms may be there at the beginning or before a person's even diagnosed. So important that we help people be on full alert as soon as possible to know that there indeed may be some changes. So when we are trying to screen, the American Diabetes Association gives us some very good recommendations. And the clinical practice recommendations from just this year have suggestions for us that are through several of the slides that I want to share. All patients should be screened for distal symmetric polyneuropathy, DPN, at diagnosis, and then at least annually thereafter using simple clinical tests. And in parentheses it says B, which tells us that there is B level of evidence. There's quite a bit of data to tell us that should be done, and there's research to support it. What are we looking for when we're talking about that high-risk foot? The general risk factors for the ulcers and amputations would be people that have had diabetes for 10 years or longer, poor glucose control, and other complications that may be associated with that. There may be vascular changes, for instance. The foot-related risk factors for amputation are particularly related to the peripheral neuropathy, and especially that person that has lost protective sensation. Altered biomechanics, evidence of increased pressure, callus, for instance, bony deformity, not just a Charcot joint, but that person who may have hammer toes, peripheral vascular disease, and we may be able to screen for that by checking for pedal pulses. And then certainly anybody who's had a previous ulcer or amputation would be at greater risk. Nails will change over time as well, but I think we particularly look for the bony changes, the vascular changes, and the changes that we see related to sensation. So the recommendations for foot care come to us that are actually probably very general and probably very well known. So while this reference is from ADA, I think there's a lot of consistency in this information. We should have an annual comprehensive foot exam and identify risk factors that are predictive of ulcers and amputations. We want to look at the foot. We're looking for any cuts or breaks in the skin. We're looking for any redness, any erythema. We want to assess for pulses, and I know it's hard to find that foot pulse, but indeed that pedal pulse is really a very important thing to screen for. The loss for protective sensation is done with a 10-gram monofilament, the Sims-Weinstein, and in just a minute I've got a picture of that just to refresh your memory. The vibratory sensation is done using the 128 hertz tuning fork. And my patients look at that, and some of them recognize it, and they think, wow, this is related to the piano. And of course it's not, but they're always, I think, kind of surprised that I pull out a tuning fork. Pinprick sensation, ankle reflexes, and vibration perception threshold. Here are the pictures that go with what we were just talking about. The upper right hand is showing the Sims-Weinstein monofilament. The 5.07 Sims-Weinstein is the standard tool for testing the bottom of the foot. And the correct way to do this is to hold the monofilament and touch it to the metatarsal heads. Hold it for about a second and a half. You bend it till it makes a C and hold it for a second and a half. If the patient doesn't say, yes, I feel that, you give them a second chance. And of course, you say no peeking. You want them to look away so they're not anticipating. And in fact, I suggest you go in a random order so they don't anticipate where you may touch next. And the majority of the foot ulcers would happen across the ball of the foot and the great toe. So you particularly want to check the metatarsal heads, great toe. You may check the heel, you may check the toes, you may check some other areas, but it's important to at least check in those major areas across the ball of the foot and the big toe. The bioseismometer, the calibrated tuning fork, or nerve conduction velocities would be other tools that could be used. A lot of people are doing the simple tools with the monofilament, and then in the lower right-hand corner, the tuning fork. There are various ways to do that. This way is showing the tuning fork held by the stem and then touched against the bony prominence. I very often will use the tuning fork right at the base of the big toenail and hold it there and ask the patient, can you feel this? And then for comparison, I like to have them hold their hand out and then also touch that same vibrating tuning fork at the base of one of their fingernails. And so then they can tell, is that vibration similar in their hand, or is it the same in their foot, or less? Very often it's a decreased sensation in their foot. There are some very sophisticated ways to do the tuning fork and count to 10. When the patient can't feel it any longer, you count while you see how much longer you can feel it, then they can't feel it. But there's quite a bit of variability in the way that turns out. And I think the bottom line here is that we want the patient to know, can you feel the vibration or not? And people know whether they can feel the monofilament. They know whether they've lost feeling, but they can't tell whether they've lost vibratory. They can't tell whether that vibration is present or not until you test it. So that begins to be a very powerful motivator for people. If they've lost vibratory sensation, we still may be able to show improvement or even reversal in that irritated nerves to their feet. So we can use that as a powerful motivator to help them get inspired to have much better diabetes control. The next slide then gives us some guidance for the recommendations on foot care. General foot care education for everybody with diabetes. In our evening class this week, we had a teenage boy, and I said to the whole class, it's important to take care of your feet. Even you, Eric, you're a teenager. We want you to use common sense. And so it's important for everybody to know they need to take care of their feet. The multidisciplinary approach would particularly be helpful for people with foot ulcers. The patient this week I saw first time that had foot ulcers, I sent them to the foot clinic and to the wound clinic. So they will have an appointment at the wound clinic first and then an appointment with the podiatrist. So they're not just seeing the diabetes educator and the diabetes doctor and their primary care doctor. They're involved with an entire team. So that group of foot care specialists needs to be an ongoing contact for the patients. They need to have lifelong surveillance. We need to work with people to stop smoking, and we need to work with them on sensation, any structural abnormalities, help them with appropriate footwear and shoes that have been specifically fitted. Peripheral arterial disease is another area related to this. And here, again, of course, vascular issues are going to have a direct impact on the neuropathic issues. So patients need to be assessed for a history of claudication, pedal pulses, potentially ankle brachial index, and then if they have significant claudication, may be referred on to a specialist. So the person in our area who's doing so much research in this area is doing a study where she is asking patients to walk. They walk until it hurts, stop, and then they begin to walk again. So she has a specific protocol with patients that she's using exercise, and of course medications or surgical options would be a consideration as well. So when I'm talking to a patient, what do I say to them? I want to be sure that they are looking at their feet every day, looking for cuts, cracks, sores, redness, swelling, anything that doesn't look quite right. And that person who can't get down there to see the bottom of their feet can put a mirror up against the dresser and hold their foot in front of that mirror to have that inspection. Wash their feet in warm water, not hot. Be sure they dry them very thoroughly. Don't soak them. Don't sit in the jacuzzi for hours and hours. Don't sit in the jacuzzi for more than 10 or 15 minutes. Talk to your doctor if you need help with cutting your nails. No bathroom surgery. That's the rule. We are very lucky to have not just podiatrists in our area, but an army of nurses that help with nail care, nail trimming, callus work, and that group of folks will go to clinics, will go to senior centers, will go to primary care physician offices all around our area, in fact, well out into western Kansas. So find those resources that are in your community and get those names and resources available for your patients. The other thing we want patients to do is look for any color changes in their feet. Choose shoes that have a deep toe box and have good support. For instance, tennis shoes. If someone does not have serious problems with their feet, tennis shoes may be able to give them good support and have a deep enough toe box to be able to protect their feet. And then, of course, don't walk barefoot. Now, if someone needs shoes, the Medicare requirements are being enforced now. I don't know that the rules are exactly new, but just in January this year, we have begun to realize that they are serious about these rules being followed. So to be eligible for diabetic shoes, as we understand the rules, someone would have to have lost protective sensation, monofilament, vibratory, heavy calluses, or absent pedal pulses, or foot deformity, or history of foot ulcer or previous amputation. And the forms that would authorize the diabetic shoes have to be signed by a certifying physician. So the nurse practitioner, the podiatrist, we're finding are not able to officially authorize the diabetic shoes. So those changes, I think, are very important for us to tune in on because we want to do everything that we need to help our patients be able to get those shoes they need them. In summary, a comprehensive assessment and thorough diabetes education on foot care are probably the two most important things to offer our patients with diabetes. In addition to very good blood sugar control, Metanax is a medical food that may be a valuable adjunct to your care for your patients with diabetes. Information on how to get Metanax is offered at the very end of your slide deck. So thank you very much for joining us for this presentation, and we will now turn it back for question and answers.
All right, indeed, it is time for a question and answer session at this point. So again, we will remind our attendees how they can send in those written questions to us, and there's a couple of different options to do that. You can certainly go ahead and type in your question in the general chat tab. It's located, again, in the lower portion of your screen. You can type your question in the chat box and then click on submit or send, if you'd like, to go ahead and send in your question. You can also email those questions to editor@neuropathy.org. We do have a number of questions that have already been sent in, so we'll begin with our first question, and we'll address this to Dr. Maynard to begin. The first question reads as follows, coming from Amy. I have been experiencing periodic nighttime leg spasms. On rare occasion, I experience an entire body spasm. Could these be related to my diabetic neuropathy?
Well, the spasms in the legs certainly could be. Patients with a diabetic neuropathy will have restless legs sometimes, and they can have cramps in the legs, and that, of course, would be treated as you would for the neuropathy with the Metanax and the gabapentin or what have you. Cramps can be treated sometimes very effectively with nothing more complicated than quinine water. Your tonic water you get at the grocery store has quinine, and bottle that at nighttime is often very beneficial for the cramps. Total body spasms, no. I don't think that will be related to the neuropathy. That, to me, sounds more like some type of a metabolic imbalance, which, of course, the diabetics are definitely prone to. So body spasms, like she was describing, that's something I would bring to the attention of the primary care physician or diabetologist. I don't think that's from the neuropathy.
All right, Dr. Maynard, very well. Thanks for the response to that question, and we'll move on to the next question, again, addressed to you. I was diagnosed, coming from Rebecca, with idiopathic neuropathy 10 years ago and diabetes 2 years ago. I feel that the neuropathy caused the diabetes, not the other way around. I say this because I have been so inactive and have gained 50 pounds since the diagnosis. I feel this caused my diabetes. Is this possible?
The diabetes is going to come from either a lack of insulin or the cells not responding to insulin called insulin resistance. So that is a metabolic abnormality. The neuropathy is a byproduct of the diabetes. I don't think the neuropathy caused the diabetes. However, that being said, if you have the neuropathy from whatever cause, and remember, a large chunk, about 40% of neuropathies remain undiagnosed. We do not know the cause of a lot of them. But if you have a neuropathy, it will interfere with activity level, balance, and walking. And decreasing activity level, of course, is the last thing you want with diabetes. You want to exercise, keep active, keep your body under control. So the neuropathy could be aggravating the neuropathy. Could be aggravating the diabetes. I do not believe that was the cause of diabetes, however.
All right, very well. We can move on to our next question. And, Debbie, this question addressed to you reads as follows from Ben. What kind of shoes do you recommend to prevent foot problems for diabetics?
The shoes that are best need to have a good, deep toe box. And we need to be sure that the shoes have a good support and that they fit well, they don't rub, and a person's foot doesn't slide. And so when you kind of think about that general description, a person may be able to have really very good support for their feet with tennis shoes. So if a person doesn't have serious neuropathy and they're just wanting to try to prevent problems, the tennis shoe may be as good as anything. Now, I think it's important to know that you may need to replace that tennis shoe every 6 months or a year. I see some tennis shoes sometimes that have seen better days. So while a tennis shoe may be much cheaper than the diabetic shoes that we discussed in the program, be sure that you have those shoes and that you replace them regularly if you need to.
All right, very well. Again, a reminder to our attendees how they can send in their questions. They simply use that general chat tab, feature in the lower portion of your screen, and then simply in the bottom box that appears, Type in your question. We'll address those questions with the time remaining for both of our presenters. Debbie, we have another question. We'll go ahead and direct in your location, and the question reads as follows. What kind of exercises do you recommend for people with neuropathy? Walking is difficult, but I hear that it's the best, and it comes from Joe.
Thank you, Mike. That is a great question. So when we think about neuropathy, if, as Dr. Maynard mentioned, people can't tell where their feet are, it becomes very important that people do exercise that helps protect those feet so they don't stumble and trip and fall. So an exercise bicycle where you may be able to put those feet into the bicycle pedal stirrups would protect the feet so you know exactly where they are, and that would allow a person to exercise. If it's like a bicycle where the arms also move, that would get exercise both upper and lower body. However, you're right, walking is as good as anything if you can have good perception of where your feet are. In our area, they open the malls early, and a lot of people do indeed walk inside in a protected area, so they're walking, but they're not outside on the rough ground or, really struggling with the weather. But I'll tell you, I have some people with a lot of complications, and they are, quite frankly, not even able to go to the mall. So if people don't have equipment at home, there are some surprisingly simple things that people could do. One of my favorite things to help people even just to get started is to say, what is your favorite TV show? Do you have one? Well, of course, everybody does. So if people can even just do some chair exercises while they're sitting in front of the TV, it's amazing if you exercise just on the commercials. In a 1-hour program, you've got almost 20 minutes of exercise. So something as simple as writing the alphabet with your foot, and while you're sitting there listening to this program, you should try it. Take your right foot, A, B, C, D. Take your left foot, E, F. You can feel that, and that gives you some good muscle movement, some good exercise. And holding a bag of beans, not a can of beans in case you dropped it on your foot, hold bag of beans in each hand and do some upper body movement. So, golly, the exercises can be as simple as something in your chair at home or as exotic as something of going to a fitness center where you have someone who's a trainer that would help you with that. Great question. Thank you.
All right, and thanks for the response to that question. And we move on to our next question. We'll throw this open to both of our presenters to go ahead and address. And it comes from Max. The question is, I was told by my primary care doctor that my neuropathy symptoms are diabetes related. I have had diabetes for 5 years now. How often should I see a neurologist and a podiatrist for follow-up care?
Well, I'll start with that. It would be important to see your neurologist to make sure there is no other cause for the diabetes. You might, for the neuropathy, you might assume it's diabetes. There are many other causes, such as lack of thyroid, vitamins, and the workup can help prevent other problems down the road if there's another cause for that which need to be treated. The neurologist would probably be seeing the patient anywhere from 1 or 2 times a year, depending if it's a mild neuropathy, if it's a severe one, up to 4 times a year. But the neurologist can help you managing the Medinex dosing, the gabapentin, the other medicines that you might need for that. So at least a couple times a year. And then Debbie has recommended, the podiatrist and the foot care, which I could not recommend more. I'll let her answer that part of the question.
I do indeed think the podiatrist would be an important person on your team, and that evaluation should be done initially, and then depending on the level of the problem, the podiatrist would make recommendation how often you might return. The part of this question, though, that I didn't hear is, should I see a diabetes specialist? And I really kind of feel like if there's some complications, that is a question you should discuss with your primary care doctor. Because, again, job number 1 is to have very, very good blood sugars. If we're going to hope for improvement, potentially some reversal in the neuropathy, we have to have perfect blood sugars. And as I mentioned, gosh, there's a lot of new medications to help with diabetes now. So it just is something maybe that the diabetes specialist would want to help you think through as well.
Well, Debbie's brought up an important point here, because this comes up with my patients very often. My feeling is this: if my patient's blood sugar is under control, they're doing well, then I think the patient has no problem staying with a primary care physician, no problems or whatsoever. But if they're having problems and the primary care doctor is working very hard, trying to get the sugars down, and they're not getting success, and I think at that point we need to see the diabetic specialist because, as you said 100 times in the talk today, good control is paramount.
I agree with that, and we have some very savvy primary care doctors in our community, and so they may be doing a great job with that. But, boy, call in the help if you need it.
Right.
All right, very well. We can move on to our next question then. It reads as follows. From Francis, what do you know about radicular thoracic peripheral neuropathy?
Okay, I call this intercostal neuralgia, which would be a neuropathy or neuralgia involving the nerve roots that come from the thoracic spine radiating around the ribs on the chest wall on one side. It has a number of causes, which could be arthritis in the spine, bony spurs. I've seen it after shingles infections, but sometimes it has no cause whatsoever. This is a condition that really needs a neurologist to check out to make sure there is no bone spur, no disc, nothing else causing pressure on that nerve root that could be causing the symptoms. It would be treated very similar to the neuropathy in terms of a medication for neuropathic pain, such as your gabapentin, your pregabalin, your Lyrica, your duloxetine, Cymbalta, what have you. Those meds are very good for that type of pain. And I've seen several cases, and it can be quite distressing. It's not particularly from diabetes. It's usually from trauma, irritation. But those patients absolutely must get a workup to find out what is the cause of that pain.
All right, very well. And again, plenty of time left for your questions. So again, a reminder, you can send in a question via the general chat tab in the lower portion of your screen, or you can also send a question via email, the email address editor@neuropathy.org. We invite you to take advantage of the time set aside for your questions. Next question up comes from Jean, who writes, is there much hope for balance issues?
That's an easy one. Absolutely, yes. The balance problem is from the sensory neuropathy, as I mentioned earlier. The brain does not know where the feet are, and the risk of falling is very real. The risk of injuries is very real. And this is where the Medinex comes in, because the medications for neuropathic pain will not help the balance whatsoever. They'll help the pain, but they won't help the sensation of the feet. And the Medinex, as I said earlier, has biopsy-proven regeneration of the axons. So the vibratory sense that you heard from Debbie will actually improve significantly. And the test I mentioned in my talk about the Romberg, where the patient will fall over and then close their eyes, that can improve. The balance problem can improve. Now, again, I'm mentioning what I do with medication. I cannot possibly emphasize enough activity and exercise. If a patient is having a balance problem, they may be inclined to, let's just stay home, sit in a chair, do nothing wrong. Your sugars will not do well. Your balance and walking will get worse. You have to keep active. You must keep walking. Yes, the risk of falling is real. Please be careful. And I never hesitate to call in the troops from physical therapy. They do a great job. I can do outpatient therapy 3 days a week, and they'll have them climb stairs and walk, and the balance problem absolutely can be improved, yes.
All right, very well. Thanks for that response to that question. We can move on to our next question, and it comes from Rose's location. Reads as follows. I'm having nail divots and dips. I've had TN for 5 years. My legs and hands are affected. Are the nail problems typical?
Who wants to take that one?
I'm not familiar with that as a
problem. I think Deb had mentioned some of the skin changes that we have in the diabetic. These are called trophic changes. And you can have, especially in the males, loss of hair over the toes and the fingers. The nails can change, the skin changes. And again, these are all due to the lack of circulation to the skin, to the nails, and to the hairs. And so we have the changes there, and it can be quite distressing. Of course, the problem is if the skin is not getting proper circulation, it can then break down. Once it breaks down, we have an infection. So these nail changes you're talking about are quite typical with the diabetes. And again, bottom line here is going to be good control of blood sugar. Those nail changes don't specifically respond to the medications for neuropathic pain or the Medinex. This would just be good control of blood sugar and make sure the circulation to the hands and the feet are in good shape.
The other thing we see, of course, is if there's a fungus, the thickened nails
Yes.
are a problem. And that relates to our discussion today, because then it becomes more difficult to keep the nails trimmed. And if the nails are long or are rubbing and causing a blister, then we set ourselves up for some foot ulcers. So other problems that may not be specifically diabetes as the cause may indeed affect our neuropathy topic today. So stay tuned for all of those issues. Be diligent.
Right. All right, very well. And perhaps you've already touched on the answer to this question, but we've had a number of questions come in relating to the following. This one from Walter's location: my hands and feet are becoming so cold I have to wear winter gloves in the house. Is there any help for this? And also Richard was wondering if this is an effect of low blood sugar.
The poor circulation will cause the cold hands. This is something that absolutely must be brought to the attention of a primary care physician. There may be a circulation problem. Again, the blood vessels are damaged in the diabetes. One advantage that Medinex has, and this is a patient I would put on the Medinex, is that we're talking about how the L-methylfolate in the Medinex improves the axons regenerate. Yes, that's true, but we have more bonuses here. There is an enzyme called nitrous oxide synthetase. This will take free oxygen radicals, convert them to nitrous oxide. Nitrous oxide is a very, very powerful vasodilator and helps to restore circulation. And the L-methylfolate is the cofactor that enzyme needs to work properly. And so this is how we're helping to improve circulation in the diabetics. And so Medinex would be very beneficial here. This is not neuropathic. This is vasogenic. It's like a blood supply. But if someone with very cold hands, please make sure you see your doctor. Let them be aware of this. They can check you for any blocked arteries. That would be a very important thing to get checked out.
All right, very well. And next question up reads as follows from Walter's location: would the atrophy of distal muscles be what is causing me to have frequent weakness in my legs that keeps me from being able to hold me up?
There are two reasons there. You're losing the muscles from the diabetic neuropathy and ischemia, and also holding you up would be the loss of sensation from diabetic neuropathy. And again, good control of sugars. Medinex can help with the neuropathy part of it. The atrophy is mainly going to be helped by exercises, and this is where physical therapy can come in. Walking, keeping active will help get the muscles to improve somewhat. But the atrophy absolutely is the diabetes, and it's due to the nerve damage and also from the lack of circulation.
And I would add, if you're beginning to do exercise, excuse me, and you haven't been exercising recently, be sure that you're checking blood sugars carefully.
Yes.
Blood sugar before you exercise, blood sugar after you exercise. And if you're on medicine that may cause your blood sugars to drop, such as insulin or the sulfonylurea family, amaryl glipizide glyburide, be sure that you are carrying something with you, even if you're with a physical therapist. You want to be sure you have something available to treat a low blood sugar. And that would be something as simple as 2 or 3 peppermint candies, and maybe then 10 minutes later some peanut butter crackers.
All right, very well. Next question comes from Kathy's location, and it reads as follows: I was told nerve endings grow back. Is that true?
Yes, that is true, and the pictures are back a few slides above the presentation here. With the Medinex, we have biopsy-proven regeneration of the nerve fibers. And again, the Medinex does not substitute for control of blood sugar, but with the Medinex, we're feeding the nerve axons L-methylfolate, so nerve axons can metabolize and do what they're supposed to do and stay alive. And they actually do regenerate. Yes, this is possible.
It's very exciting, isn't it?
Yes.
I just almost put it in the miracle category.
Yeah. To be honest, we don't cure a lot of things in neurology. You usually think what I take care of, and this is one that we can reverse, and so to me it's quite exciting.
What I say to the patients, though, when we're hoping to see some reversal is this may be a slower process than you would ever think about.
Yes.
So while you may say, gosh, I've got my blood sugars in really good control, Debbie, I've had them in good control for a month, I still am having pain, I'm having tingling.
Right.
I think it's important that patients know it was a long path, maybe years and years and years to get to that point, and it is the same path to get back.
Absolutely.
There's not a lot of shortcuts. We know some things such as the Medinex and the good blood sugar control that may speed that up, but I think it's a bit frustrating for patients, and we really should, I think, help set the expectation that, yes, this is possible, we want it to happen, and it just may not happen as fast as you would hope.
Yes, the slides I showed you here today were biopsy data at 6 months of Medinex. I usually see the improvement begin at about 3 to 4 months. It takes a long time, and the patient needs to be prepared for that, yes.
I begin to have patients report on some symptom improvement, sometimes in a month.
It's happened, right?
It's kind of exciting when that does happen, isn't it?
Right.
All right, very well. Thanks for the response to the question. Next question up from Williams location. I have sensory neuropathy and also moderate PAD. My A1C is borderline, ranging from 5.9 to 6.5. My problem is mostly sore feet and occasional tightness and the drawing up in my feet after being on my feet for an extended time. Loose socks shoe fitting makes it worse. I'm 83 and have been diagnosed PN for 15 years. My question is, what is the best program for treatment for me to alleviate the soreness and irritation and prevent worsening of the condition? I have not taken medicines in the past, but would like recommendations. My glucose readings are predominantly in the 100 to 110 range.
Well, sounds like blood sugars are in good control, but the neuropathic problems are persisting. And again, this is someone that I would highly recommend being on the Medinex to help those neuropathic problems. The other medicines, gabapentin and amitriptyline, would not be of much benefit there, but sugars are already good. And again, this is sometimes very discouraging for the patient. Well, gee, I'm really following my diet, I'm exercising, but I still have the neuropathy. Yes, that does happen. That doesn't mean go out and binge and sit and watch TV all day. No, keep following exercises. It would be much worse if you weren't doing that, but you want to keep the sugar under control. But if the neuropathic problems do persist, this is a very good candidate for the Medinex.
All right, very well. We'll remind our attendees again, plenty of Q&A time remaining. If you'd like to get your question in, simply use the general chat feature at the lower portion of your screen, or you can email those questions, editor@neuropathy.org. We can move on to our next question from Neil's location, and it reads as follows. Many patients have painful neuropathy but are not diabetic. Would you recommend Medinex for them?
Okay, I can address that. We'll do the legal disclaimer. Medinex is approved for diabetic neuropathy. That being said, I have a lot of people in my practice with neuropathy, and so I can give my own experience on that. I have many causes of neuropathy, from B12 to thyroid to cancer chemotherapy to basically unknown in a big chunk of them. And I have used Medinex in non-diabetic patients with very, very good results. Again, this is off-label. The Medinex is approved basically only for diabetes at this point. But other painful neuropathies, do I use Medinex? Absolutely yes, and with success.
All right, very well. And next question, Susan's location writes in with the following. I have neuropathy and have been going to dialysis and have gotten RLS. Are they related?
The kidney disease causes peripheral neuropathy. In fact, years ago, back in the dark ages, yes, I'm that old, we would do dialysis until the refluxes came back. If you had an area where you couldn't be doing the BUNs and creatinines on an easy basis in a small community, we had a portable dialysis machine. Refluxes will always go down with the neuropathy as your BUN and creatinine go up, and will come down as you improve that with dialysis. And so you have basically here two causes for the neuropathy, the diabetes and the renal failure, and both those causes of neuropathy are very well known to cause restless leg syndrome. Very common, yes.
All right, very well. Next question. Isaac's location writes in the following. Does L-carnitine and lipoic acid help?
I'm not aware of that. I don't know.
Alpha-lipoic acid does indeed, I think, have some data supporting it with neuropathy. And it works primarily through the help with the antioxidant benefit and reducing the reactive oxygen species. So there is some data to support that. The studies that I've reviewed recently have showed best results with IV. Oh boy, that won't be easy for us. But if people are using some over-the-counter alpha-lipoic acid, it looks like 600 milligrams a day is probably the dose that might provide some benefit. I, though, again, have seen much better results with Medinex. But yes, I think there is some information out there about alpha-lipoic acid.
All right, very well. We'll move on to our next question from Keith's location. The question reads as follows. How can I know if I have diabetic neuropathy instead of some other form of peripheral neuropathy?
Whoa, that's a good question. because there are many, many causes of neuropathy. Dr. Peter Dick, who is head of the neuromuscle department at Harvard, wrote a exhaustive textbook on neuropathy. In fact, it's so large, it's in two massive volumes that look like encyclopedias. There are many, many causes of neuropathy, and what you have to do is not assume it's diabetes, but you need to see your either family doctor or probably the neurologist to get a fairly large series of blood tests done to look for other causes. You'd be very sad to miss a B12 deficiency or a thyroid deficiency or a protein problem from the bone marrow that could be very easily treated that would not respond, of course, to just treating the diabetes. And so, again, that requires a very important workup. Anybody who presents to my office with a neuropathy, even though they've been a diabetic for Lord knows how many years, they still get the full workup. Could be missing something else? Answer is yes, and I pick up other causes basically many times a week. So we have to get a lot of labs done. You can't just assume it's diabetes. You must get the workup. That is an excellent question.
Dr. Maynard talked about lots of different kinds of neuropathy as well, and so I think that's an important part of this question. There may be focal neuropathies that happen just in one spot.
Right.
The autonomic neuropathies that are things that, we kind of take for granted, that your heart is beating, your food is processed well. So there may be some very unusual kinds of things. Most of my comments kind of centered around peripheral neuropathy. And typically, if it is diabetic peripheral neuropathy, it will be the same in both feet. So if someone says to me, Debbie, I just have tingling or numbness in one foot, that doesn't always kind of ring a bell for me that it would automatically be diabetes. That kind of makes me think there may be something pinched somewhere. But indeed, this is a very complicated area, so you can't always rely just on that little quick check.
Right.
All right, very well. Next question. Richard's location is inquiring, what is the role of iron deficiency anemia in neuropathy?
Again, very, very many causes of neuropathy, and we will always do a complete blood count in every person with a neuropathy to look for iron deficiency. If that is present, you want to correct it. There are many causes of anemia, and many of those are also causes of neuropathy as well. So that's what's one of the many long list of blood tests that need to be done. And you check the blood count. If iron's low, treat that to try to get the neuropathy better if at all possible.
All right, we'll move on to a question from Walter's location, inquiring, is a foot vibrator massager good or bad for my feet?
I'll defer to Debbie on that one. I don't know. Okay.
I don't think it's necessary.
Okay.
And I don't think it probably would hurt anything, but I think the real important thing is that a person, again, protect your feet so they're not at any risk of being injured.
All right, we'll move forward. Again, a reminder, as far as questions go, you can use the general chat feature in the lower portion of your screen to send in your questions, or you can email those questions, editor@neuropathy.org. And we have a question from Jim's location that reads as follows. I have diabetic neuropathy and excessive sweating. My doctor tells me this is an autonomic involvement. Could you please explain? And also goes on to ask, what can I do about the excessive sweating?
The sweating is what we mentioned earlier as far as being one of the autonomic functions that you're not aware of, but are maintained by the parasympathetic and the sympathetic nervous system. And when there's an impairment there, you can get either excessive dry or excessive sweating in the feet. Again, yes, I would use Medinex in those patients for the autonomic component. There are a number of drying agents that can be used. There are a number of places that are doing injections. They can inject the nerves that cause the excessive sweating, and I've seen some very good results with that. I rarely have patients have to go to that procedure, but I've had 2 or 3 in my practice. So there are some things that can be done. And I'll be honest with you, the patients that have this, it is a very distressing symptom for them. The sweating can be very embarrassing. It's affecting their clothes, their handshake, and all that, and that can be treated.
From an educational perspective, I would say try to observe what foods may trigger that more.
Sure.
My patients very often will say things like, Debbie, spicy foods seem to really set me off. And that, I think, would be something we would anticipate and predict, that a person may want to really cut back on the spicy foods and some of those kinds of things as well.
Sure.
All right, very well. We'll address Carol's question next, and it reads as follows. I have had neuropathy that I was aware of for a year and a half, In this time, I've lost a lot of flexibility in my feet. It feels like my feet are turning to stone. I do not have an accurate diagnosis of what type of neuropathy I have. What is the cause of the lack of flexibility? She goes on to add, too, that it seems like all shoes except Crocs hurt my feet tremendously, and the neuropathy has come on fast and violently.
Yeah, what she's describing here are dysesthesias, which a lot of diabetics have, but all neuropathies can have this, where a normal tactile stimulation, putting a shoe on, putting a sock on, the sheets at nighttime, any tactile stimulation, instead of being perceived as a light touch, is perceived as a unpleasant, could be burning, sharp shooting pain, whatever. And this is a clear symptom of neuropathy. And as I stated earlier, there are many, many causes of neuropathy. And the data I've seen out there is that if you look at everyone who presents with a neuropathy, okay, diabetes number 1, alcoholism number 2, but 40% of everyone coming into the office with neuropathy, we will not get a diagnosis. That's a big chunk, almost half. And so, again, this is someone that would absolutely need to be seen by a neurologist, get the labs done to try to find the cause of the neuropathy. But realistically, they may not find it. And with my own patients, I'll offer a large number of blood tests to be done. I can do genetic testing. Hereditary neuropathies are a big chunk of the cause of neuropathy, but the problem that gene testing is extremely expensive. I mean, we're talking many thousands of dollars to have that done. We can go as far as a spinal fluid examination looking for abnormal proteins. A nerve biopsy can be performed. We look at the nerve under the microscope with electron microscopy. I rarely have to go this far. These are expensive tests and don't really add that much as far as increasing the yield of a diagnosis. So if you don't have a diagnosis and you've been worked up thoroughly and you're just idiopathic, unknown, then you just get the symptoms, again, which would be a combination of, again, I would use the Metanex even if it's not a diabetic neuropathy because I can help maybe the nerves heal up somewhat, and then I would use the medications for the neuropathic pains, which would, again, be your neurotoxins, your Cymbaltas, these kind of medicines to get some improvement.
All right, we can move on to our next question, and this comes from Brenda's location. Is there something specific I should share with my pedicurist regarding foot care and my foot symptoms with diabetic neuropathy?
Oh, my, oh, my, oh, my. Be very careful with pedicures. I've gotten quite gun-shy about them since we see all the TV news shows with people having sores and ulcers on their legs. The pedicurist must clean the basin very, very well. I think the jets that we see in the foot basins are a problem in terms of getting them clean. If there's any cuts or breaks in the skin, even something as simple as calluses where there are cracks in the heels, any bacteria that's in the basin or in the jets when you're getting that pedicure may indeed cause serious problems for my people with diabetes. So be very careful. Yes, you want your pedicurist to know you have diabetes, but you want to be diligent to know that your pedicurist is cleaning, and you may want to use just a basin, not the foot area where you put your feet in the water and the jets vibrate and help that soften. So I would just say know that pedicurist well.
I could not agree more.
All right, very well. We can move on to our next question. Perhaps, Dr. Maynard, you've already touched on this, but from John's location, in cases of non-diabetic neuropathy, would Metanex offer the same benefits?
Again, we do not have data on that. All I can give you is my personal experience with a large practice in neurology, and I have a lot of patients on Metanex for causes other than diabetes, and I've had some good results. Some of the hereditary neuropathies, like we call the Charcot-Marie tooth, I've not had such a good result with Metanex because that's a inborn error metabolism, and the nerve damage is among the most severe that you can see in neurology practice. But many of the other causes that we have of neuropathy, I would give the Metanex a try. Again, as I mentioned earlier, this is a medical food, so this is defined as very, very safe by the FDA. We're probably not going to be talking about an issue with insurance since it's a medical food. Many insurances don't cover it, and so the cost is going to be on the shoulders of the patient anyways. And so will I give the Metanex a try? Absolutely, yes.
I might just expand your comment about the cost. I think there's some information on the Brand Direct and some of the ways that a person might be able to get that at a bit more reasonable cost. one of the people that I recommended it for and prescribed it for a couple of months ago said, Debbie, I am just retired. I will do some investigation because I bet we can get it cheaper. And this gentleman had been a businessman and was pretty darn savvy at his investigation, but indeed came back when he came for the start of our evening classes saying, you know what, that is the best price. So roughly, I think about $120 for a 3-month supply is probably some of the best pricing.
Yeah, the price we have in Ontario, where I'm in Indiana, it's $130 for a 1-month supply of the Medinex. The Brand Direct Health is charging $48 a month, or 3 times that for a 90-day supply, which again is the lowest I've seen anywhere. And again, be cautious, because I had one gentleman who was very happy. He had very good private health insurance, and since Medinex was not a formulary drug, was not formulary, he had a $70 copay per month, and he was very happy with that because it was a lot less than $130. When I told him about Brand Direct, where you can have it mailed to your house directly from Louisiana and only have to pay $48 a month, he was even happier with that.
That's better math, isn't
it? Right.
You know, I've had some patients that have had some substitutions, and I think that there are some really scary kinds of alternatives out there that are not the same formulation, and people would not get that same benefit.
I agree.
So we need to be cautious.
Right.
All right, very well. Oh, no, I'm sorry, go ahead.
I was just going to say the dosing might fit right in here while we're having this comment about how a person would access it. It's just a flat dose, 1 pill twice a day.
Correct.
All right, very well. We've had a number of sites in different locations ask questions about this next subject matter. And in general, the question is there a relationship between neuropathy and restless leg syndrome?
Absolutely, yes. And by that, I mean if a patient presents to the primary care physician with restless legs keeping up at nighttime, they must be checked for neuropathy. That's a very common cause of that. And I have no problems treating the neuropathy, the restless legs, with what are medicines that are called dopamine agonists, drugs originally invented for Parkinson's that are used and approved for use in restless legs and are very effective. But again, that would just be a cover-up. That would be the same thing as giving Neuron to a diabetic neuropathy without using the medics to make the problem get better. You must look for the cause of neuropathy. And again, I think someone had mentioned earlier about the iron deficiency anemia. That's a big one to be checked for in the restless legs. You must look for neuropathy and get that worked up.
All right, we can move on to our next question. Rhonda's location wondering, I have to use a walker for balance, and I'm losing more mobility. Fibromyalgia is making exercise difficult. Please advise how to deal with both issues.
Well, we've got some advantages here. We've mentioned the medicines for diabetic neuropathy, the pregabalin, which is Lyrica, and the duloxetine, which is Cymbalta. Both of those medicines are very beneficial in diabetic neuropathy. Both those medicines are approved for use in fibromyalgia. And the problem with her balance and walking here is multifactorial. The fibromyalgia will cause a lot of pain and discomfort with the walking. That interferes with it, number one. And number two, any neuropathy interferes with the sensory impairment from the feet, further compounding the balance and walking. So it's kind of, two problems at the same time here. But we have medications both for the pain in neuropathy and for the pain in fibromyalgia. And just for the record, as a neurologist, I am convinced that fibromyalgia is absolutely a very real organic disorder. I believe it is probably neurologic. I think there's some disordered perception to pain somewhere in the brain, because we have PET scans are different, spinal fluid, pain neurotransmitters are different in fibromyalgia. It's a very real condition, very painful, but it can be treated.
All right, very well. A quick reminder as well to send in those questions. Use the general chat tab in the lower portion of your screen, or you can email the questions editor@neuropathy.org. It's still about 14 minutes left for Q&A time remaining. Plenty of questions in the queue, including this next one. I know of Medinex and Lyrica for pain. Can these medications really restore nerve function?
The only medicine that can restore nerve function that exists is the Medinex. And again, not substituting good controlled sugar. We say it over and over again. The Lyrica is a great combination. The Cymbalta, the Neurontin, these medicines are good for pain control. I use them all the time and frequently with great results. But the restoring of the nerve function is good control of blood sugar, and Medinex control the neuropathic pain symptoms are the medications.
All right, very well. We can move on to our next question. Myron's location would like to inquire, when you say diabetic specialist, would my endocrinologist fill this role?
Absolutely, yes. That's the definite. That the endocrinology would be the Latin term, and diabetic specialist the English word. The endocrinologist is a internal medicine specialist who deals with anything with the glands, thyroid, adrenal glands, but the pancreas is a gland, insulin is a hormone, and so your endocrinologist is your expert. So if you're seeing an endocrinologist, you are in the best of possible hands.
I might just add to that comment, if you are in a position that you have not had diabetes education and you are looking for some help in that area, a certified diabetes educator would be another person that you might want to add to your team.
Yes.
And there are a number of education programs that have received national recognition through either the American Diabetes Association or the Diabetes Educators Association, and those that have reached that national recognition are ones that are eligible to have your insurance be able to be reimbursed.
Sure.
All right, we can move on to our next question. Keith's location wondering, how do I begin the process of getting a prescription for Medinex?
That'll come from your primary care physician or your neurologist or diabetic specialist. They simply write the script, and again, I've been recommending Brand Direct Health for their discount. I have a couple insurances that I've seen do cover the medication. It's not a large, but it exists, and I've had many times where I will send the script to the pharmacy, and I tell the patient, if they ask you to pay more than $48 for 1 month of supply to save, I'm sorry, I'll get it somewhere else, and then we can send the script to Brand Direct. And where I am here in Indiana, we are 100% paperless, a complete electronic record. I have that pharmacy memorized in my medical record. I just type in that as a pharmacy, click a button, I'm done, next patient. It's very easy. And just have someone write the script. You Medinex twice daily, either 60 with 11 refills, and then either try your pharmacy to see if insurance covers it, and if not, then I have it mailed to Brand Direct Health. It's very easy to do.
All right, we'll move on to our next question from Laura's location, and reads as follows. My blood glucose is normal, but my hemoglobin A1C is slightly elevated. My PCP told me I have prediabetes. I have burning pain and some tingling in my feet. How does the info you've given us apply to pre-diabetics, and do you think Medinex could still help me?
Yes. If she's pre-diabetic, she may already be having some of the neuropathic symptoms, and I have seen the neuropathy precede the diagnosis of diabetes by several years. This happens all the time. Many times I see a patient in the office for the neuropathic symptoms, and I ask, are you diabetic? No. And you've been checked? Yeah, I'm fine. And I do, and it's borderline just a little bit high, and okay, well, it's pre-diabetes. And again, these are people that I'm going to get probably first and foremost up the diabetic educator. Exercise, watch your diet. You control this now with diet and exercise. We may postpone by quite some time in the future the need for medications. And if they have a clinical neuropathy based on vibratory loss, import loss, whatever, yes, these are people that I would absolutely put on Medinex. Earlier is always better. These are people I can get the neuropathy to reverse very rapidly. I can get it to prevent it from progressing to the severe, painful, ulcers and all that. I've got it earlier. It's much harder when I see a diabetic who's been there for 20 years, who has ulcers and already had a toe amputation. Yes, I'll treat them. Yes, I can get improvement, but not as much as a pre-diabetic. So we want to see our patients at that stage.
I love Dr. Maynard. Ooh, isn't this awesome? I work with a doctor that says there is no such thing as borderline diabetes. It's like borderline pregnant.
Right.
You either are or you aren't.
Right.
So I think the advantage that you have by knowing that your blood sugars are slightly elevated is that you can get on full alert this very minute. And so anything you can do to make those blood sugars perfect is going to do nothing but help in the big scheme of things. So hats off to you for being so observant and astute with where you are with your parameters.
All right, very well. For both of our presenters, then we've had a couple of different questions asking about normal dosage of Metnex, or what dosage is recommended?
The recommended dose is 1 tablet twice daily. That is what all the studies were done on the biopsy data, and this is the dose that was used to get the FDA approval for this product. Again, it's a medical food, not a drug, but we did have studies, good science behind this, that shows that 1 tablet twice a day is the recommended dose. I recommend that for every single patient. Now, I live in the real world, okay? I have patients, yes, they have their diabetes pill and their Metnex. Oh, they also have their asthma pill, their blood pressure pill, their cholesterol pill. The expenses are adding up here. Yes, I get that. And I have patients where the cost really and truly is an issue. So in those patients, and I'm going off label here, this is my experience, I will tell them, look, I understand you got all these medicines, your check is tight every month. Can you just do 1 Metnex a day, 1 tablet a day? We'll cut it at Brand Direct Health from $48 exactly down to $24 a month. I said, if you can lead to 24 a month, I let them know, no, this is not the full FDA-approved dose of this product, but once a day is better than 0 times a day. And I have patients who will go on that medication, treat them for say several months. Then if they're not getting any better at the once a day, we'll have a discussion. Hey, you want to try twice a day? If they say, Doc, I just can't afford, the money's not there. Okay, well, we'll leave it at once a day, and I've seen improvement with this dose, and it's better than nothing. But the proper dose, the recommended dose, is 1 pill twice a day.
All right, moving on. Next question from Luke's location. I have CMT and diabetes. Any advice for me?
Whoa, Charcot-Marie tooth. That is the hereditary neuropathy I mentioned. You got 2 things going on here, both the diabetic and the hereditary neuropathy. Probably the hereditary, if anything, may be more severe. What we have in the EMG test I mentioned, the nerve conductions in Charcot-Marie tooth are among the lowest recorded in an EMG lab. This is hereditary. And this is someone that, again, I would put on Metnex. I probably would not get as good a response in a patient like this if they just had diabetes because they have, 2 causes of neuropathy. I would just treat them and try to get it as good as they can. And, of course, with my Charcot-Marie tooth patients, I always am recommending a lot of therapy, exercises, keep active. I give the patients the analogy that with a Charcot-Marie tooth, this is, you inherited this. I can't change who your parents were. Okay, that's you've got this. We have to live with this and deal with it. And I tell them that keeping active, exercising is like you're going on the escalator going downhill, but you've turned around, you're going up the stairs. So at least maybe stay at the same spot. So I would treat them with a Metnex. Try to exercise as much as you can, but these patients can be very difficult.
I might add that we want to be sure this person has their good shoes.
Yes.
They have good support. The Charcot-Marie foot has kind of a rocker bottom, and so they may have some demineralization of the bones, and things may not be as good an arch as we usually would see. So there may indeed need to be some offloading and some different specialized shoes and or casting that may need to be done to help support that foot.
All right, very well. And perhaps this leads into your response that you just made, but there was a comment made by Fran's location that perhaps we should mention that Medicare will pay for your diabetic shoes. Any comment on that?
I would be glad to make some comments. We have for years helped our patients get diabetic shoes and are still doing that, but we do need to be sure that you're meeting the requirements and that your form is signed by a certifying physician, which is not your nurse practitioner or your podiatrist as we understand the rules. So the foot exam, comprehensive foot exam, needs to be done, and the things that would meet the requirements for diabetic shoes would be loss of protection, so that might be the monofilament or the vibratory, absent pedal pulses, foot deformity, history of foot ulcer, or previous amputation. So any of those things would make a person at high risk for foot ulcers, and as I understand it, would indeed qualify you for diabetic shoes. And then typically once a year, a person is able to get new shoes. Those would then be fitted. There would be inserts. They would be specifically made, specifically fitted to your feet. So a podorthist may be involved with that as well, and not just something that would be sent to you in the mail.
And overall scheme of healthcare, this is something I feel strong about, that this is something you want to get started from the get-go, because doing things like Debbie's talking about, you're going to prevent a lot of problems down the road before they ever happen, and prevention defines cost-effective. You know what I'm saying?
All right, very well. Pass along just under 4 minutes or so of total program time remaining, so time for a couple more questions. Next question up is, my neurologist suggested taking curcumin with bioperine for my neuropathy. In other words, the question is, are vitamins good for neuropathy?
It's biopterin, and I've seen some information out there. I've not been doing it with my patients, but I do know neurologists that do that. It's kind of a mixed bag right now. I don't know of a lot of good data out there that either is yay or nay with that. I have no problem, with the multivitamin therapy. Again, the Metanex does contain 3 vitamins, not just the methylfolate, the B12, and the B6. Vitamins are very good. Again, we think that the diabetic neuropathy is ischemic, nutritional, not getting the nutrients to the axons the way they should be. And I use the vitamins myself. I've not been using the biopterin, but there's some that do. It's kind of a mixed bag on that one.
All right, very well. Next question from Grace's location. Guigong or Tai Chi for exercise. After wobbly start, Guigong has enhanced my balance. I no longer hang out of the wall to do it.
I'll make a comment there. My recommendations is you do the exercise that you like. I don't care what it is. Okay, do something. If it's riding a bike, if it's walking, if it's your Tai Chi, if it's whatever you want to do, doing exercise cannot be recommended enough. And the thing is, if you don't like it, you're not going to do it. So find something that you find pleasant, that you enjoy doing. Be it whatever. If it's there's all these Zumbas, and I don't care. Do something. That's my recommendation.
I would add that the new guidelines for exercise recommend up to 30 minutes a day, 5 days a week. And so, again, whatever you're doing, I agree. But the American College of Sports Medicine says exercise grazing is okay. So if it's difficult for you to be able to make time to do 30 minutes at one chunk, it's okay to break that into smaller segments. Yeah. So exercising, again, can be done any number of ways, any amount of time, and you try to get 30 minutes a day, because that constant muscle movement for those 30 minutes is the key to help with the blood sugars.
All right, very well. And with that, we've come to the end of our allotted time for questions and answers. Any closing thoughts quickly before we wrap up today's program from either of our presenters?
Well, just real quick, I sound like a broken record. I cannot emphasize diet, exercise enough. Medications are important. But again, you want to have good foot care. And the Metanex, to me, is exciting because it is a major breakthrough that I've had in my practice, where I'm not just covering symptoms, but I'm making the cause of the neuropathic pain get better. And to me, that's very, very rewarding.
And I would just close by saying, adding to that, be sure you do everything you can to have good blood sugars. Get good help with diabetes education so you can be in charge.
Thanks too much for both of our presenters for today's presentation. And with that, we'll wrap things up. That concludes our Neuropathy Association webinar today, Dealing with Diabetic Neuropathy on a Day-to-Day Basis, presented by Debbie Hinnan and Dr. Stephen Maynard. And, of course, we want to also pass along today that our program today provided by PAM Lab and the Neuropathy Association. For more information about PAM Lab and Metanex, you can visit www.pamlab.com or www.metnex.com. And for more information about peripheral neuropathy and the Neuropathy Association, you can visit that website, www.neuropathy.org. We'll also pass along some information as well about obtaining Metnex, and we'll bring that information up for you on our screen. As well, if you have additional questions, you can still send those questions via email address editor@neuropathy.org. Thank you for participation in our webinar today. Today's program is copyright in 2013, the Neuropathy Association, all rights reserved. Thank you for joining us for the program today, and please enjoy the rest of your day.